Hadirin yang kami muliakan, selanjutnya kita akan simak bersama Welcome Ship from Vice Rector University of Bangka Belitung. Please welcome Bapak Nanang Wahyudin SEMM.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Beli kain di kota Tasik. Bayarnya 4, dapatnya 5. Bukan korupsi ya. Ya, bayarnya 4, dapatnya 5. Pelajari data kesehatan dengan baik akan mendukung masa depan Anda. Yang terhormat Dekan Fakultas Ekonomi dan Bisnis dalam hal ini diwakili oleh Pak Faisal dan Bu Dian Perdini. Terima kasih atas kehadirannya. And the special, the Honorable Prof. Harper and Prof. Gardner. Welcome to Universitas Bangka Belitung. We are happy to you have here. Uh, Thank you for being our research speaker in this event. And I'm sure your sharing will give benefit to participant or student enjoying the workshop in here. And we are looking forward to collaborating in the future. Uh, I hope uh, I hope come again and again in Universitas Bangka Belitung. I'm sorry when my English not good. And I would also like to thank Pak Mursid for organizing this event and invite a valuable speaker. Uh, Thank you, Pak Mursid, and to Mr. Harper and Gardner. Don't forget to try local Bangka dishes, maybe like lempah kuning, empe-empe, or otak-otak. Oh, ini uh, lempah kuning is yellow fish soup. Maybe yellow. Oh, it's right. Yeah. That it made for kunyit turmeric ya, maybe. Turmeric. Yes, thank you. Turmeric. Uh, yeah, I think one of food Bangka Belitung. Uh, and then uh, Bangka Belitung famous tin mining and also has many uh, beach yeah beach beautiful beach maybe. So I hope uh, you have time to visit them, or maybe Pak Mursid to agenda to visit one of maybe Parai or the other beach in Bangka maybe. Ya, baik. Mohon izin. Terima kasih Bapak Ibu semua dan rekan-rekan semua. Ikuti kegiatan ini dan sebaik-baiknya. Kami berharap teman-teman yang mengikuti ini bukan hanya untuk mendapatkan sertifikat, tapi benar-benar memperoleh kompetensi dan kemampuan untuk meningkatkan skill baik untuk karirnya maupun untuk persiapan yang akan datang. Eh, Kami mengucapkan terima kasih yang sangat banyak kepada seluruh pihak yang telah menyelenggarakan ini. Dan Pak Rektor menyampaikan tidak dapat bergabung di sini dikarenakan sedang soft opening new building, Prof. Sehingga apa namanya menugaskan saya untuk mewakili beliau. Bapak Ibu hadirin yang saya hormati dan seluruh peserta yang berbahagia, selamat mengikuti acara ini. Saya buka dengan basmalah. Bismillahirrahmanirrahim. Semoga acara ini berjalan dengan lancar dan baik. Sebelum saya akhiri satu pantun penutup, burung merpati terbang memutar. lalu hinggap di pohon nangka. For Prof. Harper and Prof. Garter, don't forget to see tourism site in Bangka. Thank you. Wassalam. Wassalamualaikum warahmatullahi wabarakatuh. Enjoy workshop and enjoy Bangka Belitung for Prof. Harper and Gardner. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, Bapak Ibu selanjutnya, kita akan langsung dengan kegiatan foto bersama. Untuk itu kami undang seluruh pimpinan untuk bisa maju ke depan dan juga para pembicara, termasuk juga Ibu untuk eh, foto bersama. Untuk sesi pertama kita foto menghadap ke sini semuanya, membelakangi teman-teman peserta. Teman-teman peserta nanti boleh berdiri ya semuanya ya. Silakan boleh berdiri, boleh merapat ke tengah. Teman-teman peserta boleh berdiri silakan yang di belakang. Dilanjutkan dengan foto bersama untuk bisa maju ke depan, Pak. Kita mau belakangi eh, poster kita pada hari ini. Oke, terima kasih. Untuk Bapak Ibu pimpinan boleh bisa maju ke depan. Teman-teman boleh duduk kembali, silakan. Dok. Sorry, sorry, sorry. Boleh berdiri silakan. Ada miskom biasa. Oke. Baik Bapak Ibu sekalian, acara selanjutnya yakni workshop sesi 1 tentang pengantar data analitik dan pemodelan dalam bidang kesehatan. Let's keep on the next agenda, that is workshop session 1. The first speaker will be delivered by Professor Paul Harper. Please welcome, time is yours.
Salamat pagi. Thank you. It's a great pleasure to be here. A beautiful banker, beautiful banker. It's a, it's this is my fifth time to Indonesia, but this is you live in a very lovely city, lovely island. I already had opportunity yesterday, thanks to Pak Merced, to travel and see some beaches, try some local food. We had a lovely time, so thank you. Thank you for your hospitality. So I'm Paul Harper. I'm head of the Operational Research Group at Cardiff University. And my pleasure to start today with a talk about some of the work and research that we do. Ibu Sari will translate if we need to. I would try to be clear. If anything is unclear and you would like to ask questions, I'm fine to be stopped and interrupted if you wish to ask questions, okay? So the purpose of today, I think it's quite appropriate that of all days we come, the same day that the Faculty of Medicine also opens, because this talk is about how we apply data, science, mathematical modeling, economical modeling to healthcare, and to help improve the lives of the people in this country and indeed around the world. So this is, for some people, this will be something a bit new. How can mathematics, how can modeling data help improve patient care and improve services? So first, a little bit, do we need to press the OK on this? I can't, so okay, my battery's fine. I think I'm still going. So a little bit about where I live from. This is a picture of the United Kingdom on the top left, and the little color red is the country of Wales. It's a small population of 3 million people. United Kingdom has about 65 million people. It's a small country compared to Indonesia, right? 280 million or so. So Wales is even smaller, 3 million. And the little black dot there is where Cardiff is. So Cardiff is the capital city of Wales, and Wales is one of the countries of the United Kingdom, okay? So some photographs of Cardiff. You're all very welcome to visit us. It's a lovely city of about 350,000, 400,000 people. So it's not a big city, but it's a capital city. So we have a Welsh government, and the government in Wales is responsible for delivery of healthcare services, education, and so on. Okay, so we are right by the sea as well. Although we don't have nice beaches like you, but we have some nice coastline, but not so much sandy beaches. But it is a beautiful coastline also in Wales. We also have mountains and a lovely scenery. So you're very welcome to come and visit us. A little bit about Cardiff University. It's a big university. It's one of the Russell Group universities. This is the top 24 research-intensive universities in the United Kingdom, which includes Oxford, Cambridge, Edinburgh, Imperial, UCL, and so on, including Cardiff. So it's one of the 24 Russell Group universities in the United Kingdom, out of about 150 universities in the UK. In the last government research evaluation, every 7 years, the government evaluates every single academic in the United Kingdom about their research quality, a very intensive one-year exercise. 90% of our research across the university was categorized by the government as world leading or internationally excellent. So we're top 20 in the UK for research quality, and we came 11th for research impact. So this is how we use our research to make a difference in the real world. So whether that be in healthcare or transportation or all areas of life. So we do very well on impact. And I hope today's examples will also show how you can apply modeling to make a difference to people's lives. In terms of the world rankings, we are ranked 154th in the world. We're a big university of 34,000 students and about 3,400 staff. But importantly, also, we're very multicultural. We have 205,000 alumni, students who have graduated from 202 countries. So that's nearly every country in the world. I think there's about 205, I think. So maybe we haven't had some for 3 countries. But we are very multicultural and welcoming. It's a very safe city as well, one of the safest cities in the United Kingdom, and it's very reasonable and to live as well. Right. Have a look at this. I like the little animation. I feel so sorry for them. But how many people here like to queue? Not many. But how many hours each day do we spend queuing? That includes queuing in traffic jams. Traffic here is really good, actually, compared to Jakarta and Bandung and everywhere else. So but we spend a lot of time queuing. We spend you queue for restaurants, you queue for traffic, you queue for supermarkets. So I like to study queues. That makes me a little bit strange, right? But I like to look at queue and behavior in queues. And healthcare services are full of queues, whether you queue to see your doctor, whether you're on a waiting list for an operation, that's also a queue. You don't physically queue, but your name is on an operation waiting list, yes? And then maybe in a few months' time, you get told you can now come in for your operation. So healthcare systems are full of queues. And so the idea of what modeling can offer is to try to minimize queues, to make sure we make the most of our resources in a healthcare setting. So this is all very much about some initial work on queuing. So this is the first important message I give to people who run healthcare services. So I speak a lot to people in the United Kingdom service, the NHS, yes? And prove the thing is variability. So a very simple demonstration, which I hope you understand. So a waiting room area, for example, in an outpatient clinic or a doctor, GP surgery and so on. So it's a very simple system. Okay, this is the system. People queue. People arrive and they queue to reception. So they go to the receptionist to check in, give your details, your name, and so on. Little blue dots are people, and they join in a queue, okay? First come, first served. They go back to the waiting room and queue to see a nurse, some diagnostics, like maybe takes your weight or takes your blood pressure or does other measures, okay? They go back to the waiting room and they wait a consultant, a doctor, medical doctor. Everybody follows the same system. It's a system. Everyone has to join the queue, reception, waiting room, diagnostics, waiting room, consultant. Okay, and we need to know how many receptionists we need, how many nurses we need, and how many doctors we need in this simple system, okay? So this is a simple example of planning for a health service. You want to translate?
I just want to check. Presentations, we don't have to.
Yeah. We're okay.
Okay. So whenever you need to give explanations, penjelasan lebih lanjut, so you can raise your hand. Okay. Okay.
Okay. Yeah.
So
please.
it means that you
Yes.
can.
Okay, I can carry on. If I go too fast, sometimes I get really excited and very fast like this, but so I go slow. Okay. So please do interrupt if you don't clear. Right. So we need to know how many resources. So we've got some information, some data, not much data, but we say to the clinic, they say, well, every 10 minutes, we book in one patient. And then we speak to the receptionist, and the receptionist says it takes on average 10 minutes to check in the patient. The nurse says on average, it takes 10 minutes to do the diagnostics. And the doctor also says, on average, it takes 10 minutes to see the patient, yes? So you have 10 minutes, 10 minutes, and 10 minutes. Okay, and we don't have any data apart from just what the doctor tells us and the receptionist tells us and the nurse tells us. So we say 10, 10, and 10. So on average, it takes 10 minutes, 10 minutes, and 10 minutes, yes? And one person's booked every 10 minutes. So this is an example of a very simple simulation model, a computer simulation of that same clinic. People arrive, then service B is the nurse, and service C is the doctor. So this is an example of a simulation model, okay? A computer simulation of this same process. So watch the clock. It's going to run 24/7. So at midnight on Monday, it starts. So every 10 minutes, somebody arrives. Okay, it's a bit glitchy. It's slowing down. It's not rendering very well on the Zoom, but it's a bit yeah. Every 10 minutes. Unfortunately, it's showing nicely on my screen, but I think the Zoom call is slowing it down. But anyway, I run a simulation model, and it says that in 1 week I saw 1,005 patients, and everybody spent exactly 30 minutes in that clinic because exactly every 10 minutes somebody arrived, and they spent exactly 10 minutes, 10 minutes, and 10 minutes. Yes, that's 30 minutes. Understood? Yeah, happy with this? That makes sense. There's no variability. Everybody spends exactly 10 minutes. But I go back to the clinic and I say, well, I know not everybody spends exactly 10 minutes, because when I go to the doctor myself, I'm in the waiting room. The person in front of me maybe spends 15 minutes with the doctor, or 20 minutes with the doctor, maybe 5 minutes with the doctor. We're not machines on a production line, right? We don't spend exactly 10 minutes being processed. We have variability. We're humans. Sometimes it takes longer, sometimes it takes less. But on average, it's 10 minutes. So now I'm going to run exactly the same computer model of that same process, but rather than making everybody spend exactly 10, 10, and 10, I'm going to introduce some variability. Okay, so this is statistical variability. So I'm going to, for example, fit some sort of simple distribution to the data. So everybody spends on average 10 minutes, but maybe some sort of bell-shaped or normal-shaped distribution. So maybe, for example, 5% of people spend less than 5 minutes, 5% will spend more than 15 minutes, and 90% of people is somewhere between 5 and 15, with an average of 10 minutes, yes? So now I'm going to run the same model as before with one nurse, one doctor, and one receptionist as before, but I'm now going to sample from the distribution. So the first person, for example, might take 7 minutes to check in. The next person might take 12 minutes, then 5 minutes, then 10 minutes, but on average it's 10 minutes, okay? Understood, yeah? So I'm going to run the same model as before. And now look what happens. The same demand, but just variability in the service time. Again, it's a bit slow and glitchy, unfortunately, with the video, but you start to see queues build up. Big queues build up, okay. And look what happens now. The same system, but with variability. 1,000 people got through still, but I don't know if you can see there, the average time in the system is nearly 4 hours. So before it was 30 minutes. Now the average patient experience is nearly 4 hours in that clinic, or 2 hours rather, in that clinic, 120 minutes, sorry. So it's exactly the same system, but now I've introduced variability, and now we have a lot of queues, okay? And this is exactly the problem that healthcare planners make, because when they plan for services, they take averages, they do basic simple models on a spreadsheet. So they say the average length of stay in hospital, or the average operation time, or the average time with a nurse. And they build numbers like this, and they multiply the number of people by the average time, divide by the number of days in the year. This is the number of beds you need. The issue with this is that if you don't capture variability in your data, then you underestimate the resource needs you have to have. So the problem in the NHS is people plan on averages, and then they wonder why we don't have enough beds or enough staff or enough nurses. Yes? It's okay?
Semua paham ya?
No?
Ya, sedikit mengulas ya. Kalau tadi kan di awalnya pemodelan sistemnya itu pakai average ya, rata-rata. Rata-rata pasien datang ketemu resepsionis 10 menit, kemudian dokter 10 menit, kemudian nurse 10 menit, dokter 10 menit. Kalau pakai rata-rata, tadi sistemnya jalan, setiap orang cuma 30 menit ya. Tapi begitu dikenakan dikenalkan variabilitas ya bahasa Indonesianya, ternyata itu rata-rata bukan rata-rata, jadi 120 menit itu 2 jam, bukan lagi 30 menit ya di dalam sistemnya. Jadi dengan mengenakan variabilitas itu ternyata kan setiap orang nggak sama ya, nggak setiap semuanya 10 menit. Itu konsepnya. Yang pertama modelnya dengan yang kedua itu beda. Paham ya?
So that's what not to do. So what should you use? Now, we should use more appropriate analytical and data science methods, okay? So the discipline I'm from is operational research, operations research, analytics. It's really about a way of problem solving. So if you like numbers and you like solving problems, this is the discipline for you. So here's a problem. It's a way of thinking. We teach our students. We have master's programs in operational research and analytics. We have degree programs in computer science and mathematics. It's a way of thinking, and it's hopefully a way of solving problems. If that's been healthcare or transportation or mining or other industries, okay, it's a way of thinking. So if you're interested in this, this is actually a very good free textbook by colleagues at University of College London, UCL, in healthcare. Okay, so actually we can provide the link via Merced and can send you the link. It's a free downloadable PDF online. Okay, but it has a summary of all the methods I'm going to talk about today. There's a nice summary of those in this little textbook. Okay, and case studies. It's a very well written book. Okay, so this is a good reference point if you're interested in to learn more about operational research applied to healthcare. But in summary, I'm going to not talk about all of these, but here are some of the a bit of a lag. Oops. Oh, okay, I clear. Partner as well. So this is the kind of tools we teach our students in this area, okay, and apply to healthcare. So we have things like computer simulation, discrete event simulation, and queuing theory. I said I like studying queues. So these are mathematical methods and modeling methods to study queuing behaviors. Okay, so you've already showed you an example of a simulation model, but another one here. This is a model, for example, of an emergency department. And again,
No, it's okay. Okay. Is everyone okay now? Yeah.
online, okay.
Yes, yes, yeah.
Can they hear me?
Yeah.
I can hear online. Yes. So what's nice about computer simulations is that you can make a physical representation on the computer screen. And then you can data. So for example, what is the demand? How does the demand arrive? So maybe, for example, in the emergency department in the United Kingdom, maybe on a Monday lunchtime it gets busy, and then maybe in the evenings it gets busy. On a Friday night it gets very busy. People out maybe partying, and then they maybe have accidents or road traffic accidents on a Monday morning. Motorbike accidents. So demand changes over time. It's dynamic, yes? So the demand isn't constant in emergency departments. So it changes over time of day, day of the week, even month of the year. Winter months in UK, more dangerous driving conditions, accidents on the highway. Maybe people have strokes or heart times of year in cold weather, and so on. So demand is time. So we can model demand as it changes people, and so on. A lot of detail in these models. Really nice, easy representation, because if it runs a simulation model, simulate a day in the life of an emergency department. So people are moving around. It's a bit more continuous on my screen. It's a bit glitchy, of course, on the Zoom, but you get the people. So the consultants and the doctors say, that looks like my emergency department. Yes. There's queues building up. Oh, that's not good, right? Why are people waiting so long in the waiting room? Look at the waiting room, it's busy. And they can start to do lots of experimentations on the computer, on the model. They can say, what if we have an extra doctor? What if demand changes? What if demand went up by 10%? What if we had 3 more nurses? We can look at lots of results like the waiting time profile. How long are people waiting for service? Too long, waiting for 3 hours. How do we get the service time down to 1 hour? How many more resources do we need? How do we roster? How do we even timetable staff? Why do we staff it like this shift pattern when actually the busiest time is on a Friday afternoon? So why don't we have more staff on Friday afternoon? So these models are very powerful. They can allow us to experiment. So this is an example of a discrete event simulation model. The other example of another model in paradigm, a simulation paradigm, is system dynamics. This is a different type of simulation model. This is very powerful if you want to model the whole system of connected parts of a system. So the discrete event simulation model was very good if you wanted to look in detail at individual patients and how many resources you need at different times of day. A system dynamics model it's like a bird flying up in the sky, looking down at the whole system below, looking at how the different parts connect. The ambulance service connects to doctors, primary care connects to social community care connects to secondary acute care. So how does a whole system flow? These are very powerful models. So an example of this type of model in paradigm, actually they were used a lot in the pandemic for modeling COVID. So you don't worry so much now about individual people, but you look at the flow between whole populations. So you can model populations of 280 million people and the pandemic. So you have an epidemic type model here. Susceptible people who are susceptible to COVID, who become exposed to COVID with contact with infected people, who become infected themselves and then infect other people, and then eventually hopefully recover. So these types of models allowed for feedback and systems thinking. So you can't see the full detail in here, but you've got all the things that influence the rate of infections, like the number of contacts you make, the number of people you come into contact every day, how close you are, does social distancing work, does vaccination reduce the infection rate, and so on. And these produce nice instant graphs. These are, for the mathematicians in the room, these are just underpinned by ordinary differential equations. They're just simple rate of change equations, but they're really powerful dashboards to show to public health how you can control whole systems. Yeah.
Earlier kita lihat ada beberapa metode di dalam operational research. Yang pertama yang dicontohkan adalah discrete event simulation, menggunakan komputer simulasi. Yang ditampilkan tadi contoh daripada pemodelan emergency department. Emergency department ya di rumah sakit. Mulai dari datang, triage, sampai ketemu dokter. Intinya dalam pemodelan itu adalah queue, antrian. Ya, adanya antrian tadi lihat ya. Bedanya dengan yang satu lagi yang sistem dynamic itu lebih kepada whole system. Ya, jadi lebih menyeluruh. Ya, bisa kalau yang tadi secara detail ya, kalau yang ini detailnya kurang tapi lebih ya dari bird view, lihatnya dari atas. Koneksinya bisa lebih general, seperti emergency department nggak detail, satu persatu jalannya pasien kemana, nggak detail. Tapi emergency department koneksi dengan rumah sakit misalnya, ya, dengan koneksi dengan social service dan lain-lainnya. Bisa dipahamin ya. Jadi ada beda, dua paradigm itu beda. Ada yang mau nanya sampai di sini dulu? Ya. Sampai selesai.
Okay, later. Okay, so again, give you some more case studies. You could other things that we teach our students. So forecast of our discipline, to optimize resource, mathematically optimize where tools. Where would you optimally look? Where in bank do you put it? Lots and lots of data collected every day. That's okay. I'm still being recorded. That's good. So the whole time I wasn't before. That's good. So now I better behave. Hello. Right. So let's talk about some examples. Okay. With the National Health Service in Wales, to actually apply them to real world problems to help solve some is working very closely with the NHS. So Busari spends some time in university and some time in the hospitals working with the managers. Professor Gardner, who would speak next, Daniel's been working for 7 or 8 years now with another health board, another area of hospitals. So he spends 2 days a week actually working with clinicians and managers in the healthcare service. So it means that we actually applying our methods to real problems that are important to the hospitals, yes? And this has been going now for at least 10 years and been very successful. So I've certainly advocate, promote the idea that researchers don't just research in their lecture rooms and their offices, they actually apply their methods to make a difference to health services. This is not my slide. This actually is the slide from the NHS Wales. What are the benefits to them of the relationship between academia and hospitals? So we have access to real world data and projects. This has also generated lots of income, grant money for supervising PhD students working on projects and MSc projects on dissertations, creates impact, raises awareness of mathematical models, improves patient outcomes. And this is very important, this bottom right-hand side, this is not my figures, this is the NHS figures. So for every £1, or whatever you want to, whatever unit of currency you wanted to call it, £1, $1, whatever, they get back £12.5 in benefits. That's a good return on investment of any business, in the sense that they spend money on research and they save their money in the health services by being more efficient with their services. They can save money and improve patient outcomes, because we live in a time across the globe where there's a huge demand for healthcare. There's an aging population, and we need to do better with the resources we have. We can't just keep throwing money at the NHS. We have to be more efficient. So.
Oh.
Yeah.
Di dalam slide ini dan slide sebelumnya, Profesor Hasbul menjelaskan bahwa ada kerjasama koneksi antara akademik dengan, kalau di sini dinas kesehatan. Seperti contohnya saya dan Profesor Gardner, sebagian waktu kami digunakan untuk dinas kesehatan melakukan penelitian di sana. Manfaat dan tadi yang dijelaskan selanjutnya adalah manfaat daripada kolaborasi antara akademik dengan industri seperti dinas kesehatan. Yang ini yang terpenting bahwa mereka mengeluarkan uang ibaratnya £1 untuk penelitian, tapi saving dari segi efisiensi pelayanan kesehatan itu 12,5. Berarti ya itu benefit yang paling ini bisa dilihat Pak, paling dirasakan, yaitu intinya itu ya.
So now for some examples. So you can see some here. We've been Daniel and the team have been very involved in designing a whole new hospital. So this was an opportunity for a brand new hospital called Grange University Hospital. And Daniel and the team have been working on lots of different projects, including operating theatres, how many operating theatres you need, how many staff you need, how to schedule, to roster patients, and so forth, how to move transportation of both patients and specimens, blood products and organs between different hospital sites, maternity services. We had a maternity service after lockdown, people having more children. So how you prepare for maternity services. During the COVID pandemic, the team was very important for response for Wales to help with planning for test, trace, and protect, to trace contact tracing, how to design the system for vaccination. A lot of people, thousands of people being vaccinated in a very quick time was a huge success in UK in terms of the rate at which we vaccinated people very quickly, which was a big factor in recovery after the months of lockdown and so on. So this can all be used, mathematical modeling. Modeling and data science can be very important to help with service provision. I should remember to always press this a few minutes before I come onto the slide. Also very important is not just that we research, but also we teach the people in the health service also these methods. Just like today, we're doing some work knowledge, but to share the knowledge, to make people help, to learn. So we do, Daniel and I and Sari spend a lot of time training other people in this whole journey about how do I improve my health service. So we teach them in introduction to data science, introduction to modeling, queuing theory, simulation, just very basic though, just introductory material, which hopefully gets them excited about the topics and then learn more. Okay, so that's also very important to us, to train people in the health service. Okay, some actual examples now. So as I said, we helped to design this new £350 million new hospital, 470 beds. There's some pictures of it being built there, developed. And you can't quite see the detail, but in the middle there is a timetable. We like timetable problems as well, here for operating theatres. So I don't know if you've ever had experience of what it looks like an operating theatre schedule, but in operating theatres. There's a big hospital, and every day they have to schedule which surgeon goes in which operating room, okay? And it's competing demand. So if you're an orthopedic surgeon doing knees or hip replacements, then you want to have your patients in one of the operating theatres on a Monday morning, say. But if you're an ear, nose, and throat consultant, you want an operation slot as well. Then you want pediatric children operations, and then you've got cardiac, heart attack, emergency operations. So everyone is competing. So it's a bit like a big jigsaw, big timetable in problem. Okay, so this is an interesting example of rostering and scheduling. It's a big thing that we do in our area as well. Mathematical optimization to work out how to best schedule consultants, different specialties to different operating rooms. And without going into the great detail, I can share more detail if people are interested in the mathematics, but the complexity also is not just the schedule on the day, but it's how many beds you have for the patients after the operation. It's a bit like a 3D jigsaw, because actually hospitals tend to think about the day. So they have like different assignments. But what happens is that on a Monday morning, the consultants like to do their most complex surgeries. So they bring in the complex patients on a Monday, the big cardiac or cancer operations. But these patients stay maybe a week in a hospital bed after the operation. So what happens is by Tuesday or Wednesday, there's no beds available for the patients. They're all being filled up. So actually the constraint is not the operating theatre, it's the bed for the patient to go to after the operation. And you can't operate on someone unless there is a bed available for them in intensive care afterwards. It's not safe. So they get cancelled operations. So it's a 3D jigsaw, okay? So complex timetable. Is that okay? Stop, I'll stop.
Oke, kepanjangan mudah-mudahan masih ingat nih. Oh iya ya.
Saya bantu yang sekarang. Jadi ini ada sebuah proyek yang bagus sekali. Jadi saya sedang membuat rumah sakit untuk membangun ruang operasi. Nah, ruang operasi ini begitu kompleks, spesialisasinya banyak, ruangannya juga banyak. Nah, tadi diberikan contoh yang di tengah-tengah tadi, itu adalah timetable, schedule, ruangan mana dipakai untuk operasi mana, pasien siapa. Tapi pertanyaan pentingnya bukan hanya untuk
June and July with Merced here, one who was in Bandung. Services. So geographical region, the city and region of Bandung, and you need to wants to know how many community care clinics do I need to serve the population. So the first thing we did was look at forecasting demand. Okay, so this is the, when it comes up, this is the population of Bandung region. Oh, come on. This is really slow now. There we go. This is actually, this blue line is the actual population from your census data of the population of Bandung until 2023. The red line is the full, given the future population of Bandung and region, how many resources do we need maybe to 2030, 2040? Okay, so the first thing is to do some forecasting. So we can do statistical forecasting. The red line is the forecast. The red band is the 95% confidence intervals. Obviously, the further we go away, the less confident we are, but we can have confidence intervals around the forecasts, yes? So that's the first stage, is to forecast demand for future population of Bandung. And then we now look at how is that population distributed spatially across the city. So the yellow dots, the brighter colors are more intense populations in the city center. The darker colors are where it's less population density. So we can forecast the demand of population across the geography, across the city, yes? So this helps us to think about, well, where would we invest new resources? Obviously where the people are, right? In the big centers, in the population districts. And then we also used some open source using Python programming. Anybody here use Python, like to program language? But the students used Python to look at OpenStreetMap. This was really useful to actually get travel-in times between different parts of the city. So if, for example, the health authorities say, how many health centers do I need across Bandung to make sure that no patient has to travel more than, say, 30 minutes or 20 minutes, okay? So we have a threshold at which we say is acceptable, half an hour travel time. So we need to know, though, the travel times across the city. So we use OpenStreetMap to, or you could use Google Maps or anything you want to actually work out the travel times from point A to point B, okay? Now comes the fun bit about the mathematical optimization, okay? So I'm not going to go into detail, of course, but there are basically two ways to study this problem. You have to kind of cover the demand, the population, or you have to try to minimize the distance that you travel. You, as a patient, you would like to minimize your travel distance, yes? If you had too many centers, we could have hundreds of centers, then no one would have to travel very far. But that wouldn't be very efficient, would it? Because it'd be too many centers. If we have too few centers, then people have to travel too far. Okay, so what is the optimal number? How many centers do we actually need to make sure that everyone travels no more than 30 minutes, but minimize the number of centers we have, the expense? Okay, so these methods, optimization methods, can help us to do that. So the result here from some of the, one of the results from the project was actually the bottom red graph here shows all the new and proposed facilities, health clinics. So with 223 facilities, of which 188 exist already, we don't want to knock them down. There's no point in knocking down existing facilities. We might as well use them. But we need 35 new facilities. So in total, we have 223. So the red dots show the existing healthcare centers. The blue dots on the map show where the model suggests we need new centers, 35 new blue dots, new centers. So we have 223. And that means with a total demand every day of 60,300 daily visits, which we forecast, that means everyone will be seen, will know how to travel more than 30 minutes. In fact, the average traveling time is only 13.8 minutes. Okay, but it shows the graph. Did you want to explain it maybe?
Iya, panjang ya. Jadi ini kebetulan saya juga involved dalam proyek ini. Saya dengan Paul punya mahasiswa S2 di Cardiff. Kami membahas ini. Jadi ini adalah kasus di Bandung, di mana menentukan berapa jumlah fasilitas kesehatan yang dibutuhkan dan di mana lokasinya. Jadi kapasitasnya berapa, lokasinya di mana. Jadi tadi dicontohkan mulai pertama dengan memforecast berapa penduduk Kota Bandung di beberapa tahun. Jadi kalau Indonesia itu sering mengatakan kita 2045 Indonesia emas, pertanyaannya berapa sih penduduk kita tahun itu? Nah tadi diberikan contoh ini forecastnya sekian tahun ke depan. Nah kemudian di gambar yang sebelah sini tadi kalau masih ingat, setelah dapat jumlah populasinya di Kota Bandung sekian tahun ke depan, dicari heat map-nya. Jadi populasi di beberapa daerah itu berapa besar density-nya. Nah, dari situ kemudian diambil proporsional terhadap jumlah penduduk. Setelah dapat jumlah penduduk, kemudian tadi menggunakan OpenStreetMap. Jadi dicari dari di mana lokasi penduduk itu ke lokasi fasilitas kesehatan, contohnya misalnya puskesmas. Dalam kasus ini adalah primary health care ya. So we use the primary health care in this case. Jadi ke puskesmas itu berapa jaraknya. Jadi harapannya penduduk itu kalau dari rumah ke puskesmas ya misalnya jangan lebih dari 30 menit perjalanan ya atau sekian kilometer. Nah, itu bisa direncanakan sedemikian rupa. Nah, hasilnya ini hasilnya optimasinya ini mahasiswa S2 yang mengerjakan. Ini adalah hitungannya dari 223 yang harusnya dibuka. Sementara saat ini di Bandung, ini di kota Bandung, itu baru ada 188. Artinya ada kekurangan sebanyak 35. Pertanyaannya di mana? Nah, di daerah-daerah yang berwarna biru itu menunjukkan di mana lokasi yang kekurangan. Kenapa harus di situ? Karena kita menginginkan jaraknya waktu tempuhnya jangan lebih dari 30 menit. Kalau di sini Anda pergi ke puskesmas berapa lama? Kalau di Bangka nggak ada masalah ya. Tapi kalau di Bandung itu masalah ya. Nah, ini dibuat 30 menit. Ternyata setelah hitungan ini sebetulnya rata-rata itu sekitar 13,8 menit. Jadi ini semua model yang dikembangkan bagaimana agar kita bisa menentukan jumlah dan distribusi dari fasilitas kesehatannya. Yap. Ya, please pasti. Ya.
Standarnya sampai mengusulkan ada beberapa puskesmas sehingga jarak tempuh menjadi 30 menit itu berdasarkan apa? Maksud saya begini, apakah juga dihitung pada saat pasien menunggu di puskesmas? Kalau memang 10 menit, kenapa harus bikin baru? Gitu. Apakah akan tidak mengingat sumber daya kesehatan di Indonesia mungkin masih terbatas. Mengingat puskesmas yang saat ini di Bandung, terutama Bandung dengan 188 puskesmas dibandingkan dengan populasi yang ada mungkin sudah oke. Jadi selain menghitung ini, apakah penelitian tersebut juga menghitung waktu tunggu di puskesmas? Kemudian kenapa mengusulkan hanya berdasarkan 30 menit?
Okay, so the question is whether we consider the key time in the facilities. So that is the question. Whether we consider that. So
Okay, So this was the start of the project, right? So in the first phase of this project, which was a summer project for 3 months, we're master students. So at this stage, all we've done so far is to study the locations, optimal number of centers. the next phase would be a good thing to do exactly this, is to actually now study the queue-in times and the waiting times and the number of resources you need in each center, yes? So you could then you could ultimately combine them, of course. So you could optimize based on also minimizing waiting times and resource consumption. But for now, this was just a 3-month project. But I think it shows actually for now how many centers you might need and where you would optimally locate them. The next project indeed would be exactly using some of the queuing models that we talked about earlier, the simulation models or queuing models, to actually model congestion. So how many, in each primary healthcare center, how many nurses do you need? How many midwives do you need? These are the kind of questions I think would be the next natural step, exactly that, yeah. Yes, that was
So actually ya terkait sambil menjelaskan yang disampaikan oleh Paul. Jadi sebenarnya ini memang baru studi awal ya, dari tahun lalu kita baru mulai. Jadi baru tahap menghitung kapasitas dan distribusinya. Belum banyak faktor yang diperhitungkan seperti yang disampaikan Bu Asti, bagaimana dengan waktu tunggu di puskesmasnya sendiri. Bagaimana dengan jumlah masing-masing nakes, dokternya berapa, nurse-nya berapa dan sebagainya. Tapi sebetulnya kita sudah punya data Bu, pada tahun 2023 kita sudah survei, tapi berbasis apa yang dijawab dari kuesioner, kami memiliki sekian dokter, sekian perawat dan sebagainya. Kalau itu bisa masuk, itu akan lebih bagus lagi. Karena tentu saja di kota besar, pasti jumlahnya lebih besar. Semakin ke pinggir, semakin sedikit. Nah itu problemnya. Jadi memang ini studi awal. Terkait dengan kenapa kemudian dalam studi ini dibuat 30 menit? Sebetulnya belum ada standar yang digunakan oleh pemerintah, dalam hal ini Kota Bandung, Provinsi Bandung, Provinsi Jawa Barat, untuk mentargetkan kunjungan itu jarak tempuh itu 30 menit. Sampai kemarin kita buat itu belum ada. Nah, tapi kemudian kita buat range. Bahkan dalam studi itu kita buat 15 menit gimana, 10 menit gimana, 30 menit gimana. Jadi ini yang disampaikan ini baru yang kalau 30 menit maka kira-kira begini performance-nya. Jangankan waktu tempuh Bu, satu puskesmas itu menjangkau berapa jumlah penduduk itu masih dispute. Maksudnya orang Dinas Kesehatan Provinsi Bandung itu belum sepakat. Ada yang pakai standar satu puskesmas untuk 30.000. Nah, tapi ada yang bilang, oh nggak bisa. Oh, pokoknya satu dokter yang digunakannya itu harus mencakup 5.000. Konon menggunakan data BPJS. Nah, ini pun belum ada. Jadi sebenarnya kita ini studinya, oke, kalau ini, it is like a what if scenario. Nah, if you use this assumption, what will be the result? If we use another assumption, what will be the result? Kira-kira begitu setting penelitian ini. By car. Yes, of course. We assume that it is a average travel time, ya. Although we know that Bandung is very crowded city. Jadi kalau sudah mempertimbangkan macet, wah itu lain lagi soalnya. So if we consider traffic jam, wow.
Yes, what I mean, the OpenStreetMap gives you the traveling times, like the Indonesian work, or the Jakarta work also. You can actually make them more sophisticated. You could have different times of day, different travel times, and so on. So you can include that. So it wasn't just, it was a travel time was taken from historical travel time data. It wasn't just like without traffic. So it's trying to be realistic. But I think what Mercy was saying was exactly, the whole point of these models is to try under different assumptions, how many, so if you wanted 20 minutes, this is how many centers you need and where to locate them. If you're happy with 40 minutes, we're not, ultimately, as operational research, we're not decision makers. We provide the evidence for the health authorities to decide, but they need the quantified evidence to make a decision. But also, this is just based on travel time, but you can also say, actually, the models can also say, well, forget travel time. If you want to make sure you cover a population in a certain distance or something, you can have other objectives. Doesn't just have to be based on just travel time alone. So it depends on what you want to solve the problem. But so hopefully that answers some of the questions. But yeah. So the last example also from Indonesia. So it's work we've been doing in Jakarta for some time. So this actually is a collaboration with many organizations on the screen. So Ambulance 118, PK3D, which is a new organization for emergency services across Jakarta. Also, even the Welsh Ambulance Service, the paramedics who provide advice, and also working with a colleague in US. So the context for this this piece of work is back in when we started this work in 2020 in Jakarta. There were many private ambulances, but no coordinated ambulance service. So in the United Kingdom, if we need an emergency, so actually on the journey today to the university, there was somebody actually the Merced had to stop because someone was having an epileptic fit in the street. Okay, so we had to get out the car and help. Okay, so there was someone having a seizure, so if it was in the UK, for example, and someone was in emergency or fell off their motorbike and had nasty injury, we would phone for an ambulance. We'd phone 999 in the UK or 911 in America and so on. Yes, and an ambulance would have come free of charge. It's run by the NHS public system, and it would take you to the nearest hospital quickly. And so pre-hospital care, paramedic care is critical to save lives. Yes. Particularly if you can treat someone at the scene of the incident. So if it's going to take you a long time to travel, like maybe 40 minutes to get through traffic to a hospital, in that 40 minutes, someone could die. So what's better is to treat the patient as soon as you can with the medical care you need straight away. So ambulances are a very important part of a healthcare service, I would say. But of course, in Indonesia, many places don't have a public number. Do you have a number here in Bangkok? Who would you phone? How would you phone for an ambulance, or would you not?
I don't know.
There's no. Would you do? Maybe there are private ambulances. Maybe some people have private healthcare. They phone for the private number, but then have to pay a lot of money for the ambulance. Yes. Or maybe probably what happens is mostly you just take your friend or someone quickly on the back of a motorbike or in a car to the nearest hospital. Yes. But if that's quite some distance away, then you just hope that they survive the journey and so on. So it's not ideal. So ambulances are an important part. So our work was really looking at Jakarta, but again, it could be applied in Bangkok, it could be applied in Malang, it could be applied Surabaya, it could be anywhere. Okay, so any city or country or place, it's the same concept. Okay, so the first thing we did, actually, Busari come to Jakarta, and we did some surveys in emergency department because nobody knew how people got to hospital. There was no data collection about how people traveled to hospital. So the survey results have been published. It's an open access journal. You can read this paper if you're interested. But from the survey for 1 month survey in 5 emergency departments in Jakarta, you can see that only 9.2% of people came by ambulance, okay? And mostly they were obviously private ambulances and expensive and so on. What was concerning to us is that even for different types of medical condition, like a stroke or a cardiac arrest, people weren't coming by ambulance, they were coming by private car or even on a back of a grab bike or something, okay? So we also ask questions about why did you not use an ambulance? So people say, well, I don't know how to contact an ambulance. What number do I phone? Okay. Are there any ambulance services? Or some people knew, but they said it's too expensive. I can't afford to pay for one. So, and so on. So we also collected information about how long it takes to respond by different types of transport. Okay. So there are very few ambulances. So the whole point of the project was to think about the map of Jakarta, which is broken into 261 districts. You want to stop?
Oke, sampai di sini sampai mana yang belum dipahami? Panjang banget ya. Ini salah satu contoh kerjasama antara Cardiff University dengan beberapa institusi, terutamanya emergency service di Jakarta. Ambulans service 118 dan 119 yang dulu punya pemerintah sekarang jadi PK3D ya di Jakarta. Yang kami lakukan adalah yang pertama karena kita nggak punya data mengenai bagaimana pasien datang ke rumah sakit, pakai apa, jadi kita harus collect data sendiri. Nah, disitulah kita melakukan survei selama 1 bulan, kerjasama dengan rumah-rumah sakit di seputar Jakarta. Diusahakan sebisa mungkin cover semua area. Kemudian hasil yang tadi disampaikan adalah intinya dalam 1 bulan itu hanya 9,2% yang ke emergency department rumit yang menggunakan ambulans. Selainnya pakai apa? Nah, kebanyakan juga yang kasusnya gawat pakai motor, pakai yang nggak appropriate. Nah, itu intinya itu di situ. Untuk memberikan gambaran bagaimana sih emergency service di Jakarta sebenarnya gitu ya. Pasien datang pakai apa, gitu. Kondisi penyakitnya apa, semacam itu. Itu ya Pak tadi ya, udah. Ya, the content.
So our job was to think about the map of Jakarta and to help advise on how many, did you say this already or not? How many ambulances do you need to cover Jakarta? Where you locate them, because they stay on different bases around the city. It's a bit like the previous project. In where do you locate community care services? So here, where do you locate ambulances to cover the demand? So where is the demand going to come from? So from our survey work, we had data work about the demand across the city. What type of vehicles do you need? So traditional emergency ambulances or maybe motorbike, paramedic. So a doctor or a nurse on a motorbike who get there quicker because the traffic in Jakarta, as you know, is pretty bad. So it's very congested. So motorbikes might be quicker to get to the people quicker. So again, just very briefly to solve this, we used a combination of different methods, optimization methods to minimize travel times, and we built a computer simulation to model or mimic the movement of ambulances across the city day by day, okay, to try out different scenarios. So if you have 100 vehicles or 200 vehicles or 300 vehicles, what will be the benefit of that in terms of response times and what's the optimal number of vehicles you need? And where do you locate those vehicles to make sure you get close to where the demand is going to be? So if you think about the city here and around Bangkok, where would you put your ambulances? Obviously, you would put them somewhere where you think there's more chance of an accident or where people live. There's a big population density. Or maybe on a road traffic network where there's a big network of motorway or something where there's more likely to be easy access for the ambulance to get to someone quicker. So you think about all these things. So we've built very more detailed models, which includes TomTom data for travel times. TomTom data is fantastic. It even gives us congestion travel times in different times of day. So you can see historical data for travel times in Jakarta. So you can see how travel times have changed over the years and through the pandemic and so on, and demand changes on the roads. And the outputs are the number of vehicles you need of different types and where you locate them across the city.
Langkah yang kedua adalah kita melakukan pemodelan dengan menggunakan simulasi, komputer simulasi untuk menentukan berapa jumlah ambulan yang dibutuhkan untuk kota Jakarta dan di mana pos yang dibutuhkan yang belum ada, seperti itu. Intinya seperti itu. Jadi dengan menggunakan matematik pemodelan kita bisa menjalankan senario. Seandainya kita punya 100 berapa ambulans misalnya, itu di mana aja dibutuhkan. Jadi itu intinya seperti itu. Nah, ini yang gambar ini itu adalah pos-pos ambulan di mana aja yang dibutuhkan. Di tiap-tiap lingkaran itu ada berapa sebenarnya mobil ambulan yang dibutuhkan atau motor ambulan yang dibutuhkan. Mana yang lebih bisa membuat respon time-nya lebih rendah, seperti itu. Jadi banyak faktornya. Itu langkah kedua dari penelitian yang kami lakukan.
I agree. but some of the outputs of the work to show to the authorities would be these kind of maps of the number of where we suggest the number of vehicles would be for both emergency ambulances and motorbikes. I think one of the big things that really opened their eyes was the actual importance of a motorbike in terms of a paramedic on a motorbike. In UK, we don't have motorbikes as such. We have fast cars. They're called rapid response vehicles. They are small cars, but they get to the people very quickly. And the paramedic treats the patient, but they can't take the patient to hospital. They have to wait for another ambulance to come. So there's different types of vehicles also. And you could also imagine in some places, maybe drones. Drones could, Amazon are now using drones in the United Kingdom to deliver parcels, right? So drones. You could imagine actually drones being used to deliver defibrillators to get someone's heart started again to hard to reach areas, or maybe even in city areas. So you could think about different types of transport. Could be drones, it could be helicopters, it could be motorbikes or bicycles and so on. So you could try, these models could be used for different types of transport. But the whole point is, it helps authorities say, well, how many vehicles do I need? If I have 120 vehicles, where do I locate, and what would be the expected response time for people? How many lives can I save, the survival rates? Okay, so this is the kind of work that we've been doing. One of the things is interesting is that at one point we went to one meeting and they said, well, actually, we just need to locate our capacity of ambulances on a grid-based system. This was what the planners thought would be intuitive. They said, what if we had one ambulance vehicle every 3x3 square kilometer grid? Okay. Or what if we had 3 ambulances on a 5x5? To planners, this seemed fair, equitable distribution. Let's just place one every grid. But of course, that's too simplistic, because why? Why is that too simplistic? Because it assumes demand is equally likely anywhere across the city. And that's not true, right? Because we have higher population areas than others. Okay. And it doesn't take into account travel times or anything. Okay. So but the thing is, we can run those scenarios through a model. If you do that, actually your response times are worse by 30 to 40%. It's not a good solution. So these models can help show that this is not the optimal solution is something more like these graphs here. The distribution is very different to just a location on a grid. Is that okay?
Jadi kita melakukan diskusi dengan authority ya, seperti penyedia ambulan pemerintah. Salah satu yang kita tangkap adalah bahwa mereka mengajukan untuk menempatkan ambulan di tiap 5 km. Nah, secara logika mungkin itu seperti, oh ya itu adil ya, semua merata seperti itu. Tapi lupa bahwa setiap daerah itu kan punya density populasi yang berbeda, permintaan kebutuhan ambulan yang berbeda. Nah, dengan menggunakan grid seperti tadi, setiap 3 km, 5 km, malah responnya lebih buruk. Nah, ketimbang kalau kita lakukan dengan pemodelan simulasi yang ternyata distribusi tadi kan di mapnya distribusi ambulannya malah nggak merata kan. Ada yang lebih banyak ngumpul di seperti satu kecamatan itu atau satu wali kota, kalau Jakarta ya, lebih banyak pos ambulannya, sementara di wali kota yang lain agak jarang seperti itu. Tapi justru itu yang lebih optimal mengurangi respon time daripada ambulan itu. Intinya adalah keuntungan menggunakan simulasi itu, kita nggak mengira-ngira, ya, kita bisa memberikan usulan yang berdasarkan studi. Gitu. Jadi nggak mengguess, nggak mengira-mengira. Itu intinya seperti itu. Ya Pak, ada lagi yang ditambah? No. Sorry, I asked the wrong question. Sorry.
Okay, so this again, just some photographs over the last few years of us disseminating our work to PK3D, which is now a new organization. So there's now a number 119 as well. Not yet. Do you want to explain that? Be easy if you explain.
Ya, sekarang jadi, dulu kan 119 ya. Sekarang jadi PK3D itu gabungan antara ya pusat krisis kesehatan daerah di Jakarta, dan dia di dalamnya ada ambulan juga.
And also when we've been on visits before, just like today, we've also been running some workshops in some of these methods. Just like I said earlier on that we train people in the NHS, we're also running some methods on simulation and some queuing theory and optimization methods as well to people, health authority workers. We've also had involvement from Welsh Ambulance Service, who have been advising on some of the paramedic medicine as a discipline, helping to save lives. And also, we even have you can't see here, we even have an ambulance named after the School of Mathematics at Cardiff University. So we think we might be the only mathematics department in the world that has an ambulance named after her. So this is a real honor. Okay, I think that's a lot of case studies, a lot of information. So happy we've got time for questions, but thank you for listening. Tara Makasi, thank you.
Thanks, Paul, for the nice presentations. I think also clear presentations. Ada pertanyaan dari audiens? Wah, gak ada masalah pakai bahasa Indonesia. Nanti Bu Sari yang menerjemahkan. Tapi poinnya tadi cukup banyak ya, bahwa banyak masalah dalam dunia kesehatan itu bisa kita modelkan. Ya, problem solving itu bisa kita lakukan dengan modeling matematik. Silahkan, ada terutama yang berangkat dari kasus lokal. Jadi misalnya ada kejadian tadi pagi, Bu Asti, alhamdulillah, waktu kita ke sini tadi pagi, ada orang yang apa tadi epilepsi Bu ya. Ya intinya kejang gitu, jatuh di motor dekat apa tuh patung Krito Surong itu. Jadi kita berhenti, kita bantu, gitu. Jadi, nah kalau di sana itu mereka cepat sekali itu bisa telepon eh, 119 ya. Nah, kalau di kita kan belum ya. Rata-rata warga sendiri yang menolong. Nah, terus kemudian teman kita almarhum yang kemarin kecelakaan, nah itu bagaimana bisa cepat dilarikan ke rumah sakit kalau kita punya fasilitas yang seperti itu. Please, if you have any questions, ada hal apa yang ingin ditanyakan? Oh, ini ada Profesor Paul, ada Daniel, Bu Sari, ada Bu Asti juga dengan 118.
Maybe I could ask the audience the question.
Oh, okay.
They don't want to ask me. But from what I've told, what do you think are the most important issues for Banca in terms of health services? Where do you think are some of the issues which you think could be improved? Either public health or healthcare delivery systems, where you think, or is the system here perfect?
Oke, jadi kalau nggak ada pertanyaan seperti saya di kelas, saya balik bertanya. Oke, ya. So you have a question or answer, Anita? Oke, please. Masih ada mic di sana? Thanks.
Sorry, sir. Excuse me. I am Arita Putria, major management. Okay. Excuse me. I am speak Indonesia language. Seperti yang kita tahu bahwa yang di bank ini kan agak kekurangan tenaga paramedik, apalagi itu ambulans. Yang kita tahu rata-rata setiap ada kecelakaan pasti yang membantunya warga lokal. Dan terus yang saya tangkap yang dari poin-poin yang disampaikan oleh Prof itu apakah bisa setiap titik di kota kita ini, di provinsi kita ini disediakan ambulans di setiap daerahnya gitu. Jadi bahwa yang kita tahu kita ini kekurangan rumah sakit di pelosok gitu kan. Sedangkan juga kekurangannya ambulans yang kurang cukup memadai di pelosok itu. Nah, bagaimana caranya kita meminimalisir hal-hal tersebut? Terima kasih. Thank you.
Okay, Professor, this is actually our students for major of management. Actually, she agree about we have the same problem with what we present. So in Bangka, she said we have less paramedics, lack of paramedics, including ambulance, and also hospital. Hospital as well, yeah. Hospital is only located in the city center, yeah. Beside that, so the lack of hospital. So the question actually, how we locate this, how we fulfill these needs actually, yeah. So actually the same questions, but yeah, at least this
Exactly.
is
That's a
the Bangka context, yeah.
Exactly. So it sounds like you have also similar issues like most places, right? So it's the same problem, like increase in demand, where to locate services, how many staff you need. It's the same issue. So yeah, so hopefully, I mean, obviously the thing is that hopefully what I've told you today in terms of if you're a management student or if you're working in a health service already, hopefully some of this might inspire you to some of the methods can be really useful to help explore those questions, okay? Because what happens too much in the UK as well is that the health service is very good at saying, well, we have a problem. We need to do some solution. We think let's put in extra beds or let's do this. There's no evidence planning, there's no thought, scientific evidence or thought are actually the answer in the questions. So what our job is to make sure that people have the right tools, methods to help answer these questions. So learn some of these methods, apply them in real world, like we're trying to do in NHS. And then you at least have the right research tools to help the service develop. I mean, if you worked in Amazon, I talked about Amazon. If you worked in Amazon or worked in big companies, then, or if you design a new aircraft, we talk about aircraft, you know, air traffic control systems, Heathrow, right? I flew from Heathrow, London, one of the busiest airports. Okay. Now, could you imagine this following scenario? So they want too many aircraft arrive at Heathrow. They want to increase capacity. Okay. If air traffic control said, oh, we need to get more aircraft on the ground quicker, let's just say to the aircraft in the sky, quick land after 20 seconds, each one, 20 seconds, 20 seconds. Oh, let's fingers crossed there's no crashes, right? So it's a silly example, but no one would ever think to do that. That wouldn't be safe. You would have to, in fact, there's whole people do models of this aircraft space, you know, air traffic control systems, how many runways you need, how many gates you need for the aircraft. This is all planned and modeled. Okay, but in health services, we don't seem to do that, right? We say, oh, how many beds do we need? Oh, let's build a spreadsheet. Let's do a simple model. Let's take an average. Let's put an extra let's put another 5 ambulances in. Sometimes the problem is there's not enough scientific evidence. Amazon do very well. They schedule, they roster, they demand, they forecast. You know, a lot of industries use these tools routinely, but healthcare is a little bit behind. Okay, so hopefully, if you're passionate about trying to save lives, improve health services, some of the methods could be really useful to do that. Okay, we need to start gradually, but we can make a difference. Yes, it's a great question. Thank you. Yeah.
Jadi setelah ada penelitian IMS, baru kan kepikir, oh ternyata di tempat saya nggak ada pelayanan ambulans. Ternyata pelayanan ambulans itu penting. Kalau tadi pertanyaan Anda, bagaimana kita bisa mendapatkan pelayanan ambulans? Susah. Jakarta saja yang sudah dilakukan penelitian oleh Ibu Sari dan banyak institusi di situ. Jakarta punya ambulans sendiri yang sekarang namanya PK3D, dulu 119, punya hampir 80 ambulans. Belum yang swasta termasuk ambulans di tempat saya bekerja. Itu banyak. Tapi ternyata yang datang ke rumah sakit cuma 9,2%. Sisanya pakai mobil lain. Alasannya karena tadi nggak tahu cara panggilnya. Itu di Jakarta yang ambulansnya ada 24 jam. Tapi masyarakat nggak tahu. Mohon maaf, apalagi di luar Jakarta. Jadi kalau kamu tanya gimana, ini murni keputusan pemerintah. Karena pemerintah kita sekarang, terutama Kemkes, masih konsentrasi di fase puskesmas dan rumah sakit. Belum ada konsentrasi di fase pra-rumah sakit, itu belum ada. Bagaimana orang Bangka, masyarakat Bangka bisa punya pelayanan IMS? Ya dari masyarakat Bangka, dari anggota DPRD-nya, dari dinas kesehatannya, mintalah ke pemerintah. Bahwa sekarang sudah saatnya kita mau kemana. Kayak tadi bawanya bingung ya Pak Mursid ya. Bingung mau kemana ke rumah sakit. Dia naik motor, mau bawanya gimana. Gitu. Bingung. Teleponnya kemana? Kamu kalau minta ambulans, teleponnya kemana? Nyambungnya kemana 119 di sini? Pernah coba? Belum ya? Saya rasa sih nggak tahu juga saya juga. Karena 119 itu sambungnya ke Kemkes, di pusat krisis Kemkes di Jakarta. Nanti dari krisis Kemkes di Jakarta baru didiseminasi ke daerah-daerah, biasanya ke rumah sakit pemerintah. Mungkin di sini ke rumah sakit Soekarno ya Pak ya? RSUP ya? Bukan RSUD, kalau RSUD dia di bawah provinsi. Jadi dia akan masuk di bawah rumah sakit vertikalnya Kemkes. Gitu. Ya, jadi itu PR gede. Kalau bertanya ke Profesor Paul agak sulit jawabnya, tapi dengan ada penelitian ini kita baru ngeh, oh ternyata pelayanan IMS itu penting. Rumah sakit, gimana caranya bisa dapat rumah sakit? Rumah sakit mungkin banyak, cuma caranya si pasien nyampe ke rumah sakit gimana bawanya? Lagi-lagi ke situ. Terus sampai di rumah sakit, dokter sama perawatnya responnya bagaimana di UGD-nya? Jadi kalau kamu tanya gimana dapat itu semua ya harus ke pemerintah daerah. Political will. Ya, itu aja Pak ya.
Terima kasih Bu Asti eh, tambahannya. Tapi sedikit apa yang disampaikan Profesor Paul tadi, apa yang sudah dijelaskan tadi mudah-mudahan bisa menginspirasi bahwa ternyata segala sesuatu itu mesti direncanakan ya, ada planningnya, ada hitungannya. Jadi nggak cukup hanya sekedar oh apa yang terjadi, ada kejadian tambah orang, tambah alat tanpa melakukan hitungan sebetulnya kebutuhannya berapa. Nah tadi contoh simulasi sudah diberikan. Nah mudah-mudahan ini menginspirasi ya, terutama saya yakin di sini ada beberapa peserta dari dinas atau puskesmas atau rumah sakit dari kehadiran peserta. Nah ini mungkin bisa menginspirasi kita untuk menerapkannya di Bangka Belitung. Ya, oke. Ada any other questions? Ada pertanyaan lain? Wah ini eh, kita punya waktu sampai jam 10. Mungkin dua pertanyaan ini yang terakhir. Yang terakhir, Mas. Silakan mic-nya. Ido yang oh oke. Yang mana dulu? Oke, silakan. Silakan.
Bismillahirrahmanirrahim. Good morning, Prof. Harper. I'm Zulfanur Hasri. Sebelum ke tadi kan sudah bertanya tentang aplikasi ya Pak terkait dengan pelajaran hari ini. Kalau saya izin bertanya terkait dengan AMA, yaitu Analytic and Modeling Academic. In the step 3 model the problem. Ketika kita sudah punya data terkait dengan permasalahan yang ada, bagaimana kita memilih model yang tepat untuk menggambarkan masalah tersebut. Karena tadi bahkan untuk terkait dengan antrian saja itu banyak model yang disadarkan gitu. Nah, kemudian yang kedua tadi ketika kita melihat atau mengimplementasikan terkait dengan permasalahan dari model tersebut, data yang digunakan itu apakah data yang saat ini ada atau yang kita gambarkan ke depannya gitu, karena data kan selalu dinamis ya Pak. Nah kemudian dari data yang kita perlukan itu bagaimana kemudian kita menentukan permasalahannya sesuai dengan model yang ada.
Oke. So it is about the AMA
Thank you.
model that you show. AMA, AMA. So the point is, once we identify the problems, yeah, we define the problems. So the first, how we choose appropriate model. Yeah, because even for the simulation, we have several options, yeah. Okay, so that is a question, how we choose the model. And then the second one's regarding the data, whether we use the past data or we need to include the forecast data.
Okay.
I think that
Thank
is
you. That's okay.
the question, yeah?
That's a very
Zulfa, yeah? Okay, thank you.
Thank you. Yeah, I think that's two good questions. Very good questions. Thank you. So on the first one, which method to use? Well, yes, exactly. It's like there's different methods one could use, but I guess it's something that we teach our students as well. That if they learn the methods, but then they have to learn also the which is the most appropriate for the problem. So here's a problem. And you just need to, you start to understand, appreciate, depending on what you're trying to achieve, what is the objective of the problem? What do you want to do? So for example, if you're asking the question of how many doctors you need in the emergency department on a 5 o'clock on a Friday, then you start to understand that's a very detailed question. So you need a very detailed operational model. So then that would help you decide which method was more appropriate. If the question though was more like, how many staff do you need for Indonesia? How many nurses does Indonesia need to cover the population of 280 million in the next 20 years? Or how many more doctors do we need to start training now? That's not an operational model. That's a very strategic long-term model. So that would be a model that you would start to think about maybe more like a systems dynamic model or a long-term. So I think it's no quick answer. It's a skill that you just develop. It's like thinking. That you have a whole range of, it's like if you if you build a house and you have a builder come to the house, they have a toolkit of techniques, yes? Spanner, screwdriver, whatever, plaster, put the tiles on the roof. They know what the problem is. They have a different tool for that, just like we do as management and mathematics students. Here's a problem. Oh, let me look in my toolkit. This is the most appropriate one. Okay, so you just learn the methods and then you know which to apply. You have to, it's just come by practice really. But I think also you just know what you're trying to achieve. But sometimes actually you find that the hospitals themselves don't really know what the question is they want to ask. So this is also another skill, right? Because they say, I have a problem, but I'm not sure what the problem really is, but it's not working very well. So actually our skills also is to go and talk to people, speak to different people, find out what the problems are, observe systems. So it's an exciting career because you get to speak to people, you get to watch, you get to collect data, you get to build models. So this is the thing. The second question was about the data.
About data.
Forecast. Yes. So exactly. So if someone says to you, like, how many beds do I need in the local hospital? Do I need 300 beds, 200 beds? Well, yes. If you just used actual data, then that would give you an answer for now. But then what about next year or 10 years time? So actually, yes. I mean, we need to forecast demand as well. So maybe forecast population change. But just population change isn't always enough because actually, for example, in UK, maybe things like diabetes is on the increase. Mental health problems are on the increase, maybe also the same in Indonesia. So actually, you can't assume things are just changing at the same. You have to think for the future. You have to forecast demand for different types of specialty, different need. So yes, you have to plan ahead. So forecasting is a very important technique as well to use for our models. So again, it depends on what you're trying to answer the question. Is it like in 10 years time and so on? With silly example, so our university built a new school of mathematics and computer science, right? So maybe you have a new faculty of medicine opening today. So they said we weren't involved, ironically, we weren't involved, but someone said the largest lecture theatre will be 250 students. So this is what the new lecture, so we opened the new building, 250 students. The next year, we had 280 students. Can't even use that, they can't even get into the lecture theatre. It's too many. So no one thought ahead to plan the forecast demand. So somebody somewhere presumably said, based on actual students now, we need 250, but no one thought to forecast next year, 280 students, 300 students. So actually, you have to be make it robust for the future, yeah? But these models can be updated with data over time. You know, you can change the model, so it's fine.
Perlu diterjemahkan, Bu? Jadi ya, mungkin buat untuk yang lain ya. Pada prinsipnya setiap model itu ada requirement ya, ada kondisi ya, karakteristik penerapannya. Jadi mungkin itu yang pertama harus kita ketahui. Model ini bagusnya untuk situasi seperti apa dan sebagainya. Jadi ketika kita sudah punya masalah, kita tinggal cocokkan. Misalnya tadi contoh, kalau kita ingin menentukan berapa jumlah dokter pada jam hari Jumat di jam 5 sore, maka kita nggak bisa menggunakan model-model yang strategik, yang agregat. Pasti modelnya harus yang spesifik. Maka kita harus buat analitik yang spesifik. Tapi kalau misalnya berapa jumlah perawat nasional kebutuhannya atau di Bangka Belitung, nah itu nggak bisa menggunakan model yang spesifik. Kita mesti cari model yang lebih generik gitu ya, lebih agregat. Nah, jadi sebenarnya kalau Anda nanti belajar siapapun, model itu ada kondisinya. Jadi tidak untuk one fit for all, satu model berlaku untuk semua, enggak. Nah, terus yang kedua terkait dengan data, betul itu harus sebetulnya ya kita harus mengacu kepada masa lalu. Tetapi kalau kita memang ingin merencanakan untuk 5 tahun ke depan, 10 tahun ke depan, mau nggak mau harus kita forecast. Ya, jadi tadi disampaikan betul kita harus melihat juga forecast. Jangan sampai kita hanya melihat kondisi masa lalu. Nanti semua sudah selesai, ternyata demand sudah berubah. Akibatnya ini nggak bisa digunakan lagi. Barangkali itu ininya. I think last questions from siapa tadi? Mbak siapa? Mbak? Oke, ada pertanyaan lagi? Nggak apa-apa lah, lebih sedikit ya.
Okay, permission, sir. Introduce myself. My name is Lindiani for Major Management. Mungkin pertanyaannya bahasa Indonesia ya, Pak.
Oke.
Untuk bagaimana sih cara agar di negara Indonesia ini dapat menerapkan sistem penanganan terlebih dahulu dibandingkan birokrasi atau administrasinya. Mengingat bahwa penanganan kasus di Indonesia ini kan lumayan rumit ya, harus ada apa ya? Masukin berkas segala macam dulu, keburu meninggal gitu Pak. Mungkin gimana sih, ada nggak solusi gitu untuk kedepannya Indonesia bisa sistemnya seperti Australia, penanganannya itu lebih diminimalisir untuk administrasi atau birokrasi dari rumah sakit itu sendiri gitu. Terima kasih.
Okay. I don't know how to say that. So actually the question is in our country, yeah, in Indonesia. So the problem is the health services is not concerned to take care of the patient first. Yeah, they do a lot of administrative work first. So how we change this the questions? Yeah, how we can change the I don't know mindset or patient first, then everything's later. Yeah, about administrative work and so on and so on, so forth. Yeah, I think that is the question. Ya, betul ya, Bu Asti ya. Nah, jadi pelayanan dulu, baru ya. That is the conditions.
Great, that's a nice question. Thank you. I don't know. It's a cultural thing, I guess. Yes, it's a cultural thing. It takes the time.